So we are continuing our journey into communication, and I'll keep saying it over and over again. Anyone can look up the dose of Saxenda or criteria for bariatric surgery, but communication really is the biggest challenge that primary care providers face when they're dealing with weight management. And that's why we emphasize it so much in this course, not only from the skills standpoint, but from the standpoint of social determinants of health and how that influences the type of communication that we provide. Last week, we talked about core principles, which were outlined in a 2011 scientific statement from the American Heart Association, which I had the privilege of leading. And that's going to be guiding our very prescriptive approach this morning. So after attending the session, you should be able to provide a rationale for why the initial raising of weight in a sensitive way is so critically important. Secondly, summarize the opening the door approach, which we'll talk about in detail, and incorporate appropriate core principles into an opening the door approach. So even though the opening the door approach is very prescriptive, as long as you abide by core principles, you can obviously adopt your own variation of that specific approach. So basically last week we talked about a lot of core principles for communication. We talked first of all about terminology, how we should not use the words obese or fat or heavy in our encounters with patients with obesity. These are considered at some level to be offensive, and even if the patient isn't offended immediately, it often leaves them with a very, very bad feeling once they leave. Empathy, of course, this is an issue. It's a medical issue. It's an interaction of an individual with their environment. We want to be collaborative, never entirely prescriptive. This is what I need you to do. It's more like, well, how do you feel about these goals that we've provided for you? Do you have any ideas that you'd like to share? Allow time. Never discuss weight at the end of an encounter, very, very briefly, with statements such as you need to lose weight and exercise more. I'll see you next month. Hopefully your diabetes will be better. That patients don't like that. And medicalization, which sounds like the absolute wrong thing to do, but you want to stay away from certain sensitive issues. And as I said last week, cosmetic benefits, social benefits of weight loss are really not our concern as healthcare providers. The patients often will bring it up. I'll look better, I'll feel better, I can wear nicer clothes, but don't go there. Talk about some of the health consequences of obesity. So what we're going to do today is talk about an approach that incorporates these core principles. And we want to make sure that we use a sensitive approach after the initial encounter. So remember, even in 2019, about 2/3 of patients have never discussed the issue of weight with their healthcare provider. And so it's an ongoing thing. And it's interesting that 2/3 of American adults are either overweight or have obesity. So interestingly, you're left with that situation of how do I raise this in a sensitive way at the initial encounter with so many patients. Why is it sensitive? Well, there are many fundamental reasons, but two that I want to focus on. First of all, societal expectations. So thinness is expected in society. It carries enormous social value. You only need to watch TV or the movies. You do not see people with obesity. It conveys health, wealth, happiness, all kinds of things, popularity, and especially with young people and especially for women. So that's a sensitive issue. So when you start to say, well, you've got a weight issue, it's like it's sending the message you're not part of all of that success and all of those wonderful things that come with being thin. The second thing is that weight is often a moral judgment. And I may have said this in the first session, that even very young children start to make moral judgments about people with obesity. They are seen as having lack of self-control, lazy, uninterested in health. And therefore, when you discuss this issue with patients, they are actually hearing some of those things about themselves, because they've certainly heard it from other people. It is even more sensitive when you're dealing with childhood and adolescent obesity when you're speaking to a parent, because not only does it indicate some of these moral judgments, it also suggests to the parent that, hey, maybe I'm not such a good parent. Maybe I'm letting my child eat in an uncontrolled way or have an unhealthy lifestyle, and that reflects on my parenting. So imagine how sensitive that is. So here's a corollary that will tell you how sensitive you need to be. If somebody was your adult patient, you would never say something like, do you need an HIV test? Have you been pretty promiscuous? If that's the way you communicate with patients, you've got some serious issues there. You can imagine that the response is not going to be very positive. So if you are initially insensitive, I guarantee you, you will probably close the door permanently. It doesn't mean the patient will walk out or refuse to discuss the issue of weight with you, but they just will not engage in a way that's meaningful. And that's why it's so critically important. So opening the door is a very prescriptive approach. Why? Well, first of all, it's true that I did come up with it. However, it has been adopted by the National Academy of Medicine as part of their core competencies for obesity communication. And it's on page 49, and I'll show you next week just to prove it to you that it's there. And so there is no randomized trial about how one ought to best discuss weight with patients. You can imagine that would not be easy. You don't have the multiple different approaches and compare them. But it was an approach that was adopted over many, many years through consensus, and mostly by what you ought not to do. So this young man has obesity. Yes, he